Patient number 1 is a 52-year-old female. Chief complaint, past 3 months of depression that's been worsening, has a pertinent history of depression. History of present illness includes 10-year history of depression. Currently on Cymbalta over a year ago due to back pain, was on Prozac, has increased fatigue, increased back pain, and voiding small frequent amounts, has urgency. Denies diarrhea, constipation, and weight loss. Has a decreased appetite, no nausea, vomiting, has intermittent heartburn, drinks 3 cups of coffee and a Mountain Dew daily. Irritable often. Occasional headaches relieved by Tylenol. Past history includes depression, chronic back pain, panic attacks, gestational diabetes. Medications include Cymbalta, Tylenol, Advil, muscle relaxer as needed, and Ultram as needed. Her last Ultram fill was 3 months ago. She also takes over-the-counter Zantac 2 to 3 times per week. Allergies were not asked. Prior illness and injury include depression. Hospitalizations, appendectomy in 1992, cholecystectomy in 2000, childbirth. No family history of illness. Social history includes she is a widow, 2 adult children, unemployed, non-smoker, no illicit drug use. Physical assessment includes temp of 99.2, pulse 94, respiratory rate 22, and blood pressure 128/82. She has a recent 10-pound weight loss. Abdomen is soft, non-tender, bowel sounds times 4 quads. Neurologically, she has fine tremors, appears anxious, and speaks rapidly. Eyes, nose, and throat are normal. She has slight fullness in the neck. Lungs are clear. Differential diagnoses include number 1, a thyroid disorder is highly likely, fullness in the neck, sore throat, depressed mood, anxiety, panic attacks, and weight changes. Number 2 includes her medication, Cymbalta, due to this highly likely due to side effects of fine tremor, appearing anxious, worsening clinical symptoms, weight changes, and urine urgency. And then number 3 is UTI, moderately likely due to urine urgency, low-grade fever, worsening back pain. Questions for the preceptor would be reasons for the neck fullness. Does she think the irritability and anxiety could be signs of bipolar? The plan is to taper the Cymbalta dosage, then discontinue due to patient possibly experiencing side effects. Start Prozac 20 milligrams PL daily, and then check urine dipstick for UTI, check serum, CBC, and thyroid, and a B12 level to rule out some of the reasons for depression. Consult psychotherapy if needed. Education on caffeine use due to headache, anxiety, and heartburn. Continue Ultram as needed. Severe back pain. Second patient is Mr. D, 59-year-old male. Chief complaint is dysphagia, difficulty eating meat. No major pertinent diagnosis. History of present illness includes him being here in the office 3 weeks ago for allergies, was treated with Flonase. Now today he is having the dysphagia. He is able to swallow fluids, but it does get stuck in his throat. Complains of fatigue, weight loss, denies nausea, vomiting, diarrhea, or constipation. And current medications include metformin, lisinopril, over-the-counter Zantac, and Hytrin 2 milligrams. Prior illness and injury includes his history of GERD, alcohol abuse, type 2 diabetes. A1C is currently 6.4, and that was 2 months ago. Hypertension, which is controlled, BPH. He had an appendectomy at age 14, gunshot wound to abdomen at age 29. No significant history for family. He is currently, social history includes incarceration, current smoker, and alcohol use. Significant alcohol use. Physical assessment includes 59-year-old male, height 5'10", weight 169 pounds. Vital signs are stable. He's alert, no added distress. Lungs are clear. No complaints, abdomen soft, non-tender, bowel sounds times 4. First differential diagnosis, I would include GERD, which is highly likely because of his history of GERD, complaints of dysphagia. However, he is not complaining of abdominal fullness, bloating, or belching. Second differential diagnosis includes esophagitis, likely due to dysphagia, history of alcohol abuse, contraindicated though because of not complaining of any heartburn. And then the third differential diagnosis is diabetic gastroparesis, which is highly not likely. He only had one rationale, dysphagia, for that. Questions for preceptors would be, how common is diabetic gastroparesis, and do we need to do an oral exam for sores in mouth to rule out esophagitis? The plan is to do an EGD to rule out esophagitis, CBC to check hemoglobin for bleeding, hemoglobin A1C for monitoring, start omeprazole 20 milligrams every day for 8 weeks, give samples to get started while we look for financial solutions for medications.